disproportionately affect low-income populations. And our fieldwork backed up what the experts were telling us. We found that less than 4% of a sample of hospitals in Nigeria and India where we did our fieldwork had effective phototherapy. And effective phototherapy means this intense blue light. The problem wasn't just the cost of the devices. A phototherapy device that you would find in a hospital here is about $3,500 US. We learned that in Nairobi, in Cairo, devices were as much as $9,000, $10,000. We also saw with fieldwork, it wasn't the retail price that was a problem. Most of the devices were fluorescent tube bulbs. So you can imagine 6 fluorescent tube bulbs, they're medical grade. Those were a real pain to buy several times a year and get shipped to hospitals around the world. So my background is engineering and product design, and I think from a technical standpoint, I looked at it and I was like, affordable blue light, how hard can that be? Famous last words, right? And at the time, and this is for the wonks in the room, there were some really exciting technological advances. For example, blue LEDs really started to be manufactured in the late 2000s, the first decade of 2000s. And you may remember that 3 physicists actually won the Nobel Physics Prize in 2014 for blue LEDs. And this is key, because if you can use blue LEDs, you don't need to use fluorescent tube bulbs. But I did have 2 life experiences, work experiences before coming to D-Rev that structured my thinking, particularly around technology that had this incredible promise of good. My first is that I worked at Kickstart International in Kenya, which I know many of you know does treadle pumps for smallholder farmers, and they've had incredible results. Farms that use the pumps see a 3-fold in earnings from their crops. I also worked for the US government doing reconstruction in Iraq in 2004, 2005. And while these 2 jobs seem very different, they both offered technological solutions. Kickstart offered the treadle pump, the water pump, reconstruction, power plants. The US government's intention in Iraq at the time was, we're going to build a lot of these state-of-the-art power plants, generate electricity, the economy will get going after years of sanctions. We know, looking back, that that didn't quite happen. And if you think about it, it makes sense. Technology in itself isn't going to do anything. I learned at Kickstart, you have this amazing water pump. It has to be made. It has to be made high quality and consistently. It has to get to farmers. Ideally, you have a business model like they had where it was purchased and it could be scaled. And then you have to think about repairing. What happens if something goes wrong with a pump? How does it get repaired if it's going to create impact? And power plants actually aren't so different. Power plants need fuel. The fuel needs to get to the power plants. Once the power is generated, it has to be transmitted and distributed to homes so that when someone turns on a light, it actually turns on. So I learned early on that innovative technological solutions don't always get to the people who need it, that we needed to consider the system around the product. Our theory of change at D-Rev was that we could address a gap in quality healthcare with a contextually appropriate product. And contextually appropriate, I meant it was designed for the market, it was designed for the environment, things like voltage surges, things like not enough nurses. And operationally, we wanted the product to scale in an economically sustainable way. So we took the best practices from business and sold it, built margins in for it to scale. And our early goal with Brilliance was that, if we could prove a model in a hard-to-reach market that wasn't being served and we could build in the profit, we would demonstrate to the established medical device companies that they too could serve, thereby closing the gap. I should note, at the time, 2010, again, we were 3 people, and fully aware that we were not going to do this on our own, so we needed to bring in partners. A key partner we brought in was Phoenix Medical System. We showed up with a prototype and got a meeting with the managing director, who was very late meeting with us, but we were patient. But we convinced them, and they're the largest maker of newborn equipment in India, to license our product. And we did it with terms that set the price and also rewarded them financially for reaching the hard-to-reach hospitals. And I should mention that while we wanted to tackle the problem globally, India was our primary target. Many of you know that it represents 20% of the world's live births, and it also is by far and away have the highest infant mortality. So with Phoenix in 2012, we launched Brilliance, and we have a photo, actually, if you could put it up, please. There it is. So far, so good. We were on our way, and it felt like, to mix it to too many metaphors, that we were in our final chapters, but it turned out that we were just starting our journey in terms of creating impact. From the first lot of 25 brilliances, so the first 25 that were made, that came off the line, 5 went to a distributor in the Philippines. And while we were happy they were reaching a high-need market, the distributor there marked up the price 5 times. So they were sold at $2,400 US. And this was depressing, considering that we had designed for affordability. So we learned very quickly that we couldn't expect to control the price, or the retail price, once our product was sold to a third-party distributor. And as a nonprofit with a mission, we also found that once the products went international distributors, we couldn't track if they were being installed. And this was important, obviously, because if we're trying to prove a model, if we're trying to close a gap, we need to know that not just are the devices going out there, but they're going to hospitals that need it, and they're actually using it. So we responded by starting to vet distributors. We went to a range of high-priority countries, tried to get our way in with the ministries of health. We met all the distributors. And I have to say, the US commercial service is great in helping make introductions. Phoenix at the time, our partner, was selling already very well in India, and they were looking to expand internationally. So with our field work, we were able, and our vetting of distributors, we were able to make recommendations to them about which distributors they should prioritize. One of the side benefits we found was actually in having all these conversations with distributors and ministries and hospitals in a broader geography than we had started with, we learned so much more about the range of challenges and the range of markets and needs, which is useful to our other projects. One thing I'll just mention we did test was a direct sales model. So could we sell directly to a hospital in Kenya, cutting out the middlemen, thereby controlling the price? It turns out hospitals in many cases would prefer to pay a higher price, not necessarily 5 times, but a higher price because they had someone local they could call. Trust was very low in many of our markets. So we ran into a range of other system barriers, which I'll just mention a few of them, because some of them are kind of interesting. We ran into inaccurate treatment protocols, and these are all barriers to impact. We ran into trade blocks based on country of origin. It turns out if you're a Pakistani hospital, you are not allowed to purchase devices from India, which does not seem like a way to punish India. Legal threats, we had legal threats from a large multinational that also made a phototherapy device. We ran into protectionist regulatory requirements. We saw funny tendering specifications. So tenders are the big government orders. One of the specifications said, when you bid on this, you have to provide a phototherapy device and a bug zapper. We also ran into corruption. We were starting to learn that the system we needed to think about was not the system around the product, but the system around the problem. So the system, what do we need to change to create the impact? So it's now 4.5 years after Brilliance's launch, and is it working? So time will tell. I'm an eternal optimist, but I also believe you're not done until you've really closed the gap. As of Q1, we've treated over 400,000 babies with Brilliance, and we expect to surpass 1 million by 2020. Brilliance devices are in 50 countries, almost all of them lower middle income. And to give you a sense, the cost of doing all this was about $2 million. Most exciting, though, I have to say, as someone who spends a lot of time visiting hospitals, is that now we actually see effective phototherapy devices in hospitals. Mostly still urban areas and main medical centers, but this is not something we saw when we started the project. And the best news of all is that in India, quality devices were around 1,500 when we entered the market, locally in certain areas, and now they're competing head-to-head with Brilliance at $400 or $500 in India. So people ask us why we're a nonprofit. We would be dismayed by that price drop. But we're a nonprofit because we want to close the gap, and we don't want a child anywhere to suffer brain damage or death, especially from an easily treatable condition. We're a nonprofit because we want to close it. And we don't want babies placed in the sun. So there are still challenges, and there will be new challenges, and there are more health challenges. We're now 18 people at D-Rev. In addition to jaundice, we work on 2 other areas of newborn health. We work on respiratory distress, which accounts for about 15% of infant mortality globally. And we also work on newborn nutrition, which a doctor, also in India, called the new frontier in newborn health. And the reason is because breast milk, as many of you know, prevents many other conditions that can relate in death. We also work in assistive technology, so we have a prosthetic knee. If you're interested in that, I brought it because it's the only of our devices that is easily portable. We're also testing the more mundane aspects of product scaling. Sales. We have an experimental sales laboratory that asks the question, how do we reach high-need hospitals faster using a market-driven model? If we step back, though, from all of this, and we look at the big picture, there's some really good news. Based on the global burden of disease, there's a finite number of health problems that disproportionately affect low-income populations. And we, as a society, have the know-how and we have the tools to solve them now. We believe that you can create health equity through revolutionary design of systems around impact. And in my lifetime, and I'm 45, or soon to be 45 at the end of the month, I want to see quality health care everywhere. No matter where you live, if your child becomes ill, you should be able to go to your local hospital, confident she will receive the best care. She won't be placed in the sun. She won't be referred to a hospital that's a day's drive away on bumpy roads. She shouldn't have to be flown to another country for care. But she'll be treated effectively and close to the people who love her. Thank you very much.